Great. Well, let me just start off by welcoming everyone who's here. It's great to have 14 folks on the call. We might have more join us. But as we get started, just to give a little background, we started doing these virtual assemblies and the in-person assemblies in the spring at convention just a year and a half ago. So this is our third or fourth assembly, and it really is a chance for the leadership of OPA and the members of OPA to come in together and talk about issues that our members have identified as really important to them. So every time we've asked the membership, what do you want to talk about at the assembly? What are the most important issues facing psychology and psychologists in Ohio? The issue of practice and how to get paid, how to get reimbursed and be successful at this has come up. Now other issues have also come up, so we've taken those other issues. We talked about how to help the communities who are dealing with gun violence and in terms of recovery from gun violence. We talked about the opioid crisis in the spring. And today we get to talk about reimbursement and practice issues with some time at the end to really look at our strategic plan draft and give input particularly on the items relevant to practice. So both in our strategic planning process and at other times we've heard that this is an issue for our members, and we want to see if we're doing everything we can and help you do what you can be doing to make sure you're getting reimbursed well enough to live well. So I love that there's such a diversity across the state of Ohio this morning. I encourage you, if you're somebody who has a hard time speaking up in a new setting, to go ahead and be brave and speak up, either, chiming in on a discussion, asking a question, or posting something in the chat that we can respond to. I see a number of us from the board of directors on here, but we also really want to hear from you, especially if you're not on the board of directors, because we don't get a chance to hear your voice as often. So that's my introduction. If you look at the agenda, you'll see Eric's going to introduce Dr. Arnold and Dr. Broyles. They're going to then provide some background information on reimbursement and practice issues, how OPA supports that, how APA supports that, and some practice models that you can use. And then we'll basically have an hour discussion where we're going to talk about these issues and see what's most relevant to you, what do you most need, and what can we take away from the discussion today. And then that last half hour from 11:30 to 12, we'll be able to get your input on the strategic plan. We're hoping to finalize that in just a few weeks at the next OPA board meeting. So that's our plan for the morning, and I'm going to turn it over to you, Eric. Also, as a caveat, I may step away for a second to get a cup of coffee, but I have thoroughly read the background, so I won't be missing too much. So that's my intro, and I'll turn it over to you, our president-elect, Eric Merkel.
Thank you, Catherine, and good morning. And again, on behalf of the board of directors, your elected officers, and our professional staff of OPA, we certainly welcome each of you to participating in this virtual assembly. This, as Catherine mentioned, came through some of our survey work as a topic of great interest to our membership, and then part of our value for the association, we wanted to make sure that we were being responsive. So we have a couple distinguished guests today. First and foremost, and I don't know, Dr. Arnold, have you been able to join us yet?
Yes, I'm on.
Fantastic. Good morning to you, sir. So today we have three different distinguished guests that will be joining us: Dr. Kevin Arnold, Dr. Jim Broyles, and then later towards the last half hour, Dr. Justin Dewberry, who will be supporting us as we talk about our strategic plan. So first of all, I would like to introduce our speakers, and again, remind each of you, if you are not asking a question, please keep your Zoom on mute. Just don't forget to unmute yourself to ask a question. We have found over lots of these different types of online meetings that there's a lot of ambient noise and different things that sometimes can intrude. I'll try to keep monitoring our group chat as well, so please also feel welcome to contribute there. So starting this morning is Dr. Jim Broyles, and Dr. Broyles is the Director of Professional Affairs for the Ohio Psychological Association. He has been a member of OPA since 2002. He has served a lot of different roles within our professional association, from Finance Officer, President, Insurance Committee Chair, Marketing Task Force Chair, LGBT Committee Chair, and has been a member of numerous committees over the years he's been involved. He co-chairs OPA's Leadership Development Academy, which is a pipeline for us to invite and have new leadership join the association. And Dr. Broyles has a practice in Grove City, just south of Columbus, and specializes working with children, adolescents, families, and LGBT issues. In addition, I'd also like to introduce Dr. Kevin Arnold. He is the president for the Center for Cognitive and Behavioral Therapy in Columbus, which has offices in Westerville, Hannah, and Dublin. And congratulations, it sounds like soon to be open in Dayton as well. He is president-elect of APA Division 42, past president and finance officer of OPA, and served as the then publications chair. He served 2 terms on the Ohio Board of Psychology, including 1 year as its president. Right now, Dr. Arnold serves as president of the American Board of Behavioral and Cognitive Psychology, vice president of the Council of Specialties in Professional Psychology, chair of the American Board of Professional Psychology Foundation, a commissioner on the APA Commission for the Recognition of Specialties and Proficiencies in Professional Psychology, president of the Behavioral and Cognitive Psychology Specialty Council, and an item writer for the Association of State and Provincial Boards of Psychology EPPP 2 exam. He's a frequent speaker for APA on business and practice and alternative practice models, and a national speaker in the development of enhanced co-location models for independent practicing psychologists. Certainly, Kevin, thank you very much, given that introduction, that you could afford us some time today. And then later this morning will be Dr. Justin Dewberry, who is a senior organizational psychologist with the VHA National Center for Organizational Development in Cincinnati. And Dr. Dewberry will be supporting us as we start talking about the strategic plan. So at this point, Dr. Broyles, you have about 5 minutes to give your backgrounder. Then we'll go to Dr. Arnold and back to Dr. Broyles, and then we will begin with our larger discussions as well. At this point, before we begin, does anybody have any technology issues or any logistics problems we need to try to help support you with? Okay. Well, Dr. Broyles?
Could we just remind folks too about the chat feature on the side one more time? I think we probably have had a couple of people who have joined us and they may not be able to be heard. And I just want everybody to be able to see that chat feature on the side and how to access that.
Yeah, that's a great point. So, excuse me, if you put your mouse toward the bottom of the screen, the little toolbar will come up there where you're able to chat, mute, unmute, stop the video. If a dog or a kid gets in the video that you don't want in there, you can stop the video and restart it. You can leave the meeting there. So feel free to use that toolbar if you're joining us by Zoom, and feel free to use the chat feature to introduce yourself, etc. Eric, I see someone's distracted by the fan, I think in your office.
Yeah, that sure looks like that. So we will address that.
Okay.
We don't want to add any unnecessary strobe features here.
Awesome, thank you. All right, well, thanks everybody. Jim, go ahead and take it away.
So I'm going to be, I really would love to have this be an opportunity for everybody to just be able to ask questions. I'll give you a little bit of an overview of what I'm thinking about, and it's part of the handout that was attached to your information that you received here through email about this town hall meeting. But my hope is that most of this time can be about your opportunity to be able to ask me questions. When I was asked to give some back or to just talk a little bit about, my introduction and what we do through OPA, I was asked in part, what is the current priority for insurance issues for OPA? And so that's an important part of what I want to make sure that, I'm pointing out. Everyday practice issues, and especially those insurance issues, are a really important part of what we want to provide support for through OPA. And so right now, my role is as the Director of Professional Affairs. And, we've done a little bit of reorganizing with my position since my predecessor left this position, Dr. Bobby Celeste. And right now, with this new reorganization, my job is almost entirely working with giving support with insurance issues. So I am a main resource for us with the with our insurance difficulties, or with the help and support that we need through insurance. And part of what I'm doing right now is I'm developing and continuing to look for significant ways of staying in touch with everyone around some of the important stuff we need to, information that we need to get out for people, or allowing people to have access to me. And I work pretty closely with Karen Harden, who's our Director of Communications, on how to proceed with getting information out to folks. But right now, I have an ongoing blog, and that is published both on the website and comes out to all members through a blast email newsletter that we send out called OPA Notes. And then the notes article that you receive through that email links to my ongoing blog. So, and what I'm doing is writing articles and providing information for folks about important issues through that blog. In addition to sending out the information, I'm also available for consultation, individual consultation. Really the best way of reaching out to me is through my email, and you can find that link to my email on the website. I can't remember if I put it on this information sheet. I don't think I did. I should have done that. But you can go through the website, through my blog, or through the OPA Notes newsletter to reach out to me through email. You can also give me a call on all of my emails that you might receive from me. There's a telephone number that you can use to reach me directly. But what I do is I provide advocacy support and individual consultation for our members. So if you're having some difficulty with a particularly thorny insurance issue, you can give me some information about that, or you can reach out to me. Sometimes I can give you individualized information about how to help with that. Sometimes I do, I have some pretty good contacts with the insurance companies, and I can go to bat for people directly with difficult issues. So either one of those are, an important part of what I do. In addition, I do, I work very closely with our insurance committee. OPA has an ongoing committee established for gathering information about insurance issues and addressing those when they come up. And I'm a part of that committee, and we, we meet regularly once a month to look at some of those issues. An example of some of the work that the insurance committee has done recently, we completed a survey. There was some, talk and question about, what psychotherapy times and what psychotherapy billing codes people are doing, what length of time people usually spend in psychotherapy in session. And we did a survey about that recently and gathered some information about that. I'm always looking for ways of, giving information or tips to people about, what are some things that what are some everyday things that people can do to support the practitioners in the private practice area. If you have any ideas about, like important information about tips that we can do, I'd like to hear information about that. Kevin's going to talk a little bit about like some private practice tips that are really, really essential for people in our changing, insurance world. In the bigger picture, OPA also does some bigger picture advocacy work in the insurance world. So for example, right now, I am a part of a coalition along with Michael Rainey, who's our executive director, and Dr. Matthew Capizzuto, who is one of our members and our insurance committee members. And the three of us are a part of a coalition that includes members from the social workers, counselors, clinical counselors, psychiatrists, drug and alcohol counselors. And together we are meeting regularly to really look at some of the experiences, problems that we currently have that emerge from interacting with the insurance companies. And we're looking for ways of coming together to speak with one collective voice to the insurance companies saying, hey, here's some problems that we're having, some concerns that are emerging, and here's some things that we would like to ask for. So, we also do some, work on that bigger picture level. And, in terms of advocacy, and that's not nearly as invisible, but it's hugely important.
Great. Thanks so much, Jim. So that 5 minutes went really fast, but you'll have another 5 minutes in a minute. Dr. Arnold, would you like to go ahead and talk a little bit about your background information for our discussion? For about 5 minutes as well.
Good morning, everyone. Thanks for joining us this morning. I'm going to talk a little bit about one aspect of where I believe the future of independent practice is going, and in particular, address what I've found at the national level is a little bit of a misnomer about independent practice and larger healthcare practice delivery. First, I'm going to talk, though, for a moment about alternative practice models. If some of the folks who are participating this morning are in independent individual practices or small group practices, I'm sure that there have been times where you felt that you're in a David and Goliath relationship with some of the carriers, particularly the large ones like Anthem or Optum. What may not be aware to some of the folks on the call is that there are different models to join together that don't violate the infamous antitrust issues. And those models in particular are sometimes referred to as independent practicing associations or management service organizations. In an independent practicing association, practices can join together. There's a formal process by which everybody forms, and you're able to negotiate on behalf of all the practices with a single carrier. There's some parameters around negotiating that are legal, and I won't get into them because the time won't permit, but it does permit for a single contact point to a carrier, and you can bring to bear the leverage of larger numbers. In a bigger way, if you wanted to join together and deal with many carriers at the same time, a management service organization is a way for a practice or practices to create shared costs over various administrative functions, and also have the management service organization deliver the message of the various member practices to a carrier or multiple carriers about the fee structures and their happiness or unhappiness with those fee structures. If you wanted to see an example of how either one of those looks, the APAPO website has some of those examples. In fact, if you take a look at the material written by an attorney that APA's hired named Kevin Ryan, they're quite good. Let me turn my attention now to how we can, as independent practices, integrate into primary care. So the notion of integration, a lot of you've probably heard about integrated behavioral health care. Its technical definition means that you're on a team and you're in an office waiting for folks to kind of show up, and essentially that you're probably being paid whether you're seeing a client or not. And that's one form of it. It works very well, in my opinion, at hospitals or hospital-owned primary care practices, or even very large primary care networks that can afford to hire psychologists for that. But if you want to remain independent, a model that you may want to look at is enhanced co-location. The term is gaining some steam. Co-location, at its bare bones, is putting an office inside a physician's office. But enhanced co-location takes on some of the other functions and adds value to your presence in the primary care office. So enhanced co-location includes hallway consults with physicians, specific ways of sharing your electronic health records or records with the primary care physician's office, things like that. In our office, we're moving to the point of providing patient education seminars once they're diagnosed with things like for adults COPD or kids type 1 diabetes, and as well every other month physician workshops over lunches to educate them on the types of behavioral health services to be delivered for their patients when they have comorbid disorders. But the point of the notion of enhanced co-location is that you remain independent. You're not an employee and you're not owned by the healthcare practice. I will say that I believe the future of psychology is going to include a substantial portion of us working in collaborative or cooperative ways with healthcare providers, much more than we're used to in the past. And we'll end up enhancing our value. This goes to the third point on the outline you see that I provided. And that is, how do we provide value to physicians and third-party payers beyond what we already provide? We should never assume that we're not providing value right now, but we can provide enhanced value. The value to physicians through some of the things I just described can ultimately save them as much as 1.5 minutes to 2 minutes on average of their regular office visit with their patients. Certainly not everyone is going to be saved that way, but when you take the savings of folks who are presenting with behavioral health problems and take a 10-minute well visit and turn it into a 25-minute visit, when they can turn to their patient and say, well, we have Dr. Arnold co-located here, let's make a referral to you to Dr. Arnold, and you can discuss those issues with Dr. Arnold. When that happens, that extra 15 minutes turns into an extra 2 minutes, and there's a tremendous savings in efficiency for them, and that they value that. Third-party payers value it because we can deliver meaningful reductions in high-cost healthcare utilization on things like emergency room visits and tracking the initiation and continuation of prescribed medications. The value is such that in our practice, we've been able to enhance our fee-for-service rates pretty substantially, either through negotiations, because we're co-located. Right now, we're co-located or will be co-located under agreements in 7 practices. We've been able to negotiate pretty substantial increases in the fees themselves, or negotiate what are known as value-based contracts, where we get increased fee bases for the, by meeting certain metrics on things like reducing emergency room visits and, excuse me, and initiation and continuation of medications when appropriate.
Great, thank you so much. Oh, Dr. Arnold, could you wrap up in about 1 minute?
I can. What I was going to do was, in fact, wrap up. Thanks. God knows people who know me know it's hard for me to ever wrap up. The thing to be considering is that our services, when they're delivered in a primary care office, actually produce those outcomes even when we don't target them narrowly or specifically. That's what the research tells us. So that's what we bring to healthcare, and that's why healthcare started to pay so much attention to us in the last 2 years.
Wonderful. Thanks so much. Dr. Broyles, you were going to talk a little bit about marketing and how using marketing can help folks enhance their practice.
Well, the main thing that I would really encourage everybody to do is take a look at the webpage where we talk about the background of our current marketing task force and where they can download our marketing toolkit. So, you know, since our last strategic plan, we've had that as a feature of something we've been focusing on with OPA. And we have a toolkit available for folks right now to help them, you know, market their practice, tips on marketing, who to market to, why marketing is important, learning how to enhance your communication about areas of specialization. It's all right there in the marketing toolkit. And the one thing that I guess I would like to emphasize for people more than anything else, most of it's right there in the toolkit. If you take a look at it, you can get some good ideas about it. But it's important to remember that in the current insurance world, in the insurance universe, unfortunately, most insurance companies are working with the idea of panel providers, and most of us know about that. In other words, if you take a look at any given person's insurance plan, all of the behavioral health providers are sort of there, and they, in many ways, psychologists are lumped together with clinical counselors and licensed independent social workers, and it is to the insurance company's advantage to portray all of us as being equivalent, each of these professions as being equivalent. Obviously, we don't agree with that. And the marketing toolkit and thinking about marketing practices is one great way for individual psychologists to distinguish themselves in the marketplace. In other words, it's a great way to demonstrate to the public or create greater public demand for, what we do as psychologists and demonstrate how what we do is exceptional in many ways. And if that demand is there, it's harder for the insurance companies to continue to portray all of us as being equivalent. So that link's right there in my handout. Please take a look at that.
Great. So we've got about an hour then to discuss. And so I really just want to open the floor and encourage folks to ask questions, to address issues that are relevant for you. Some of our discussion questions are, what are some of the specific practice problems that we should be discussing that would be helpful to you? What are some of the ways that you have found helpful in your own practice? And what are you hoping for from this assembly? What would you walk away with in an hour and feel like that was a really good use of my Saturday morning? So go ahead and chime in, and let's see what folks are bringing to the table this morning.
I would love also, Catherine, to hear about what are specific insurance barriers or issues that you're experiencing right now that, maybe I can help out with.
Great.
I'm looking at our group chat. So if for whatever reason you can't, if you're saying something and you feel like you can't be heard, feel free to type it right there and I'll take a look at it.
Jim, this is Michael Ranney. We've seen a lot on our listserv lately about people getting letters from insurance companies threatening audits because they're using certain codes more than their peers use them, and having longer sessions than the insurance company says is the norm. What have you found out about that can help people deal with that issue?
We could do our whole, you could do a whole session just on that alone. The Reader's Digest version of that is that a lot of people are really, in some ways offended by some of the push that we're getting right now from the insurance companies about moving to that 45-minute session. So, with what we get from insurance companies, it feels to me like there are always different layers to it. There's the more outward stated layer of this is why we're doing that. And then there's always that more underlying kind of hidden agenda kind of reasoning underneath that. And that one's harder for me to get to. I can only surmise it through observation. But what I would say is that, many of the insurance companies right now are pushing to have the standard psychotherapy session be that 90834 45-minute session. And the way that they're trying to push people to do that are through those audit letters that many people have received. And what we're thinking right now at this point is that most of that is what I would call, a threat or a threat letter. In other words, there's some obvious efforts with those audit letters to intimidate people, to try to make them think, okay, here's something that I need to go ahead and do, and I need to stop billing the longer 60-minute session. But they're actually not requiring it, with the exception of United Healthcare, who I believe is requiring pre-authorization right now for the 90837 60-minute session. So, we watch this closely. When I look at things like this, I work closely with APA, with our attorneys from the Department of Regulatory Affairs, with the APA, and we all, and the other DPAs in the other states, and we're all kind of put our heads together about this. And one of the things that we're thinking about and strongly recommending right now is don't change your clinical, practice approach. Don't change that, but maybe for right now, use your clinical judgment as you see fit. Okay, and the most important part of it is make sure that you're following record keeping guidelines, and those are available again on my blog. And that includes making sure that you're recording start and stop times. And what we're thinking at this point is if they want to actually audit people around this issue, they'll probably be going in and looking at your start and stops times to make sure that you're actually recording, that you did spend that, or that you actually did spend that full 60 minutes with that client. So again, don't change what it is that you're doing. And my thinking behind all this as I'm observing it is if they could actually require us to use the 45-minute session instead of the 60-minute session, they would have done it right now. So the fact that they're using scare tactic tells me that there may be a problem with actually requiring it, so they're trying to use this other approach.
And Kevin, I wonder if you could maybe
I was just
that conversation too.
Well, yeah, let me target the records issue, if I could. If some of you are on electronic health records, if some of you are not, I'd encourage you to move to electronic health records. It'll increase your efficiencies once you get through the learning curve. The electronic health records, through the scheduling function and typically through an automated function about when you log into the record and sign the record, will typically, if you log into the record at the onset of the session, and if you sign the chart note once you're done charting at the end of the session, will record the start and stop times either in an audit log or in the chart note itself. And it helps, excuse me, to keep track of the amount of time that you're in the session to document and justify the codes you're using. The unfortunate reality is that while they are called procedural codes in the CPT manual, ours are not procedural codes per se, but they're timed codes rather than I performed this codes. And those time codes are used sometimes in those audit processes. We found that when we do the response to the audit, we have a series of steps that we always follow. It's possible in REHR to save and close a chart note and forget to sign it if you were going to add something a little later. So our electronic health record produces an unsigned document report that permits you to remember to go back and finish the note if there was something you were going to go back a little later and add a point to. That step of looking at unsigned chart notes is a part of a larger audit process for us. We get a letter from I forget the name of the company that does it for Anthem. We go back to the billing records and cross-reference the billing records for each of the sessions billed to the chart notes to see if there are any unsigned chart notes that haven't been completed yet on the billed units. We really discourage people from doing that, but it happens from time to time, as I'm sure you know. So the first thing is to make sure that everything you build is documented in your chart notes. The second thing I'd suggest is making sure as you go through them, all the chart notes have been signed. If you're using paper chart notes, they need to be signed with a signature electronically in EHRs. And then we typically send them the non-psychotherapy note component of our protected health record for each session, along with the billing record and the intake, of course, to document medical necessity to show that the intake included the right kinds of assessment strategies to produce the diagnoses, which are then the basis for the billing. Those are the steps that we always go through. We audit everything like that, we compile it, in our office, we have admin staff that do that, and then it's reviewed with the clinician before the documents are sent out.
Great, thanks, Dr. Arnold. What other questions do folks have? I notice a couple people are starting a practice or looking to start a practice. Other folks may have established practices. What got you to join the call today? What are you hoping to get answered?
I have a brief question. So what I've learned, and I'm not really too familiar with this because I work in a hospital setting, but I do work with children and adolescents. And what I've learned is that oftentimes, a lot of services that we provide for children and adolescents is actually qualified to meet criteria for interactive complexity. And I'm really not sure when it's appropriate to use that, or if I should use it all the time, or if those codes are even being reimbursed. So I have a question about that. Should I be using more of those codes, or should I avoid them altogether?
Well, do you want? I think there are a couple of ways to answer that question. This is Kevin. One has to do with the technical definition of the complexity code. That has to do with the need to have whatever creates the complexity and the additional individuals that are required to come into the session in order to meet that need. Excuse me. So I think there's that technical side of it to become super familiar with. And if you're in a hospital setting, to go downstairs and talk to the coders and find out exactly what they're going to look for to see whether or not you've met those criteria. Because hospitals have coders who, read medical records all the time and actually create many of the build codes for the physicians. But another way to answer it is to point to the resources. APA's got quite a bit of resource on this, and in particular, the outgoing past president, Tony Puente. This is his thing. Coding. He's just known for knowing everything about coding. So if that question needs a deeper drill down beyond the definitions and checking maybe with the coding staff or an expert coder, because those folks are out there too, even if you're not in a hospital, I would suggest going to APA and contacting the practice organization and getting a question over to Tony. He may have already written something on it, but if he hasn't, he's a very gracious person. He'll put something together very quickly for most folks.
Dr. Arnold, I have a question about that. You mentioned other people who need to be in the room for the complexity code to be used. Is that a code that folks can use in solo practice at all?
Let's take, for example, I haven't built a complexity code in a while, so let's see if I can pull the toolkit out in my head. And if I'm wrong, Jim, please God tell me. But let's say that you're having a session with a child who's been sexually abused, and that's beginning to emerge, and a part of the session requires some emotional content discussion that the child won't do with just you in the room, which requires that you might bring in, let's say, maybe they were brought by a children's services worker or another trusted adult who's not in the room, and you need to bring them into the room to facilitate the contact. That would, as I recall the complexity code definition, those two issues would then meet the definition of a complexity code, and you could code it. Because you're having to do more work. It's complex because you're doing more work by engaging a third person in the room, and you're dealing with a complexity issue that requires that you get additional resources than the typical ones required of the psychotherapy session.
So, to be honest with you, I mean, what Kevin is saying, makes a lot of sense to me. And this is an area that I'm a lot less familiar with. But I guess what I would add to it is that to remember that all of these codes have definitions. And so the definitions are set by AMA. And so the you know, Center for Medicare and Medicaid Services sets guidelines for the other insurance companies to follow to the documentation guidelines. So in other words, if you're billing this code, here's the documentation that you should be, you know, showing. So what I would say is if you're working in a more complex system, you know, where that coding and that billing is being done for you, I would be really well aware of what coding is being done and making sure that you're following those documentation guidelines. If you're in a private practice setting, it's different. Most of us in private practice settings know what codes we're billing. And so what I would do then is just make sure that you're becoming familiar with you know, the definition guideline and then following the documentation guideline that goes with that.
Great, thanks for the question, Elizabeth.
And let me just add, I went ahead and looked up the CMS guidance on it while we were talking. So the key points to billing a code, I was pretty close to being right. There has to be a complication during the interaction that disrupts communication among the patient, between the patient and the provider. And it can include things like emotional reactivity or extreme anxiety. And then in order to implement the treatment plan, you're being hindered because of the display of that increased complexity. And then, excuse me, it requires that you have to engage a third party in order to manage it, or when you have to engage some form of equipment, say an adaptive device, in order to facilitate some kind of additional communication beyond the communication that you're typically using in the session. So those things would constitute the 90785 according to the CMS. But again, if it was a question I had, I'd go to APA, APO, and I'd specifically ask Tony Puente.
Yeah.
So Elizabeth, if you listen to what Kevin's reading there, those key components are the things that I would make sure I was documenting. You know, what the complication was, the thing that bring, and here's the thing, if you have coders who are doing your coding for you, you know, it might be a good idea to make sure that they understand all those key components, because sometimes it's hard for us to understand. That could be coding something.
Great.
Yeah, I would add.
I think that's
Jim's
probably
point.
the bigger. I think that's the bigger issue, because in our setting, a lot of the coding is done for mainly the physicians and the psychiatrists. For psychologists, they aren't really familiar with what codes apply for us, and we're doing a lot of educating to them about like what's most appropriate. Hence the reason I'm asking this question. So it would be really nice to have this information, bring it to them, so that when they do establish the codes for us, or if they do approve codes that we apply, then they have appropriate information to do so.
This is Kevin. I would completely agree with you. I've seen over the last couple of years medical practices and hospital systems increasing the hiring of psychologists, and a sort of failure to recognize on the front end how little they understand about how to code our services, and frankly, how to collect the fees for our services after the coding. Because clearly the methods of denial of claims and the reasons for the claims denials, as well as the coding issues, they're not super complex, I don't think, but they're completely unfamiliar with the 908 codes and 96101. And they don't know, many of them, how to get them paid when there's a denial on the code. So there's a lot about us being in medicine, when medicine, like you're employed in a hospital, or if a physician hires a psychologist, there's a lot that's going to go on there that can affect the success of the psychologist from the hospital's financial or the practice's financial goals. That is going to it's going to go beyond what the psychologist is typically thinking that they're doing. But at the same time, it's simply the result that the medical system doesn't understand the codes and understands what we do.
Great. Yeah, I really see some resources coming up on the chat feature. Folks are talking about how Medicaid doesn't include that code. Folks are using the code for people who've suffered a stroke and use nonverbal mechanisms for the session. There's also a call here to talk about reimbursement for telehealth. And there's another question here about things like prolonged exposure that are 90-minute sessions. How do those get billed? So maybe we could take the telehealth question since it came first. So the question from Dr. Williams, thanks for submitting that, is can we talk about reimbursement for telehealth and how is that going for folks?
You know, there was a time when, you know, telehealth wasn't being recognized at all by the insurance companies. And I think what's happening now is that more and more insurance companies are recognizing that and allowing that. I don't have an exhaustive list right now of the insurance companies who do, but it is a good idea to maybe take a look at and find out more about which companies do and do not. I could probably, we have an entire committee here within OPA who takes a look at our professional practice committee right now is working a lot with telehealth, and I should probably get with them and find out some of the nuts and bolts about that so I can get that out to people. Be another good project for the insurance company, I think, is to find out more about which companies are allowing that and which are not. A couple of things to remember with telehealth, though, is that, you know, there's a lot of you know, it's not just about, you know, I'm going to Skype a session instead of doing an individual face-to-face session. So there's some really important security guidelines that need to be followed. And when you're billing a telehealth session, there's an actual location code that needs to be included with that. So, you know, there's some parameters around that that are important for people to be mindful of.
Yeah, I'm wondering if other members on the call are using telehealth at all, if anyone has thoughts about that, or Dr. Williams, if you've started using it, if you've been able to get reimbursed.
I can say that we're getting ready to implement telehealth after the first of the year, which necessitated for us having our attorney develop a HIPAA compliant form for consent that also addressed the issues for not only psychologists under the board rules, but also for social workers and counselors, because we have those providers in our office as well. It took about, I'd say, a month for him to develop that form, but we now have that form, and we'll be including it in our packets so that we can deliver telehealth largely during inclement weather. Last year, during the blizzards that hit us, or the snowstorms, I thought they were blizzards, in January and February last year, we didn't have a way of overcoming the logistical barriers. We've also done a fair amount of research with each carrier about what codes to bill when there's a requirement for a modifier on the code to let them know that it's telehealth. Those are the kinds of issues that you have to kind of drill down into. But we've been compiling that, and I think we'll be ready to go by January 1st.
Great. Anyone else using telehealth and getting reimbursed for that? I know Eric Sullivan, our previous finance officer on the board, was starting a telehealth practice as well, but he's not with us today. So it does, I remember him talking about, Dr. Arnold, some of the background work to be ready for that and know how to bill for it properly and have it all set up. Yeah. So if there's no other discussion on that, there is a question about billing techniques such as prolonged exposure that are 90-minute sessions. Do you all have ideas about how to bill for that, or is anyone else billing for that kind of manualized treatment that has a session longer than 60 minutes?
So in general, the insurance companies are recognizing that longer section, the 90837, as being that's what they actually identify as being the extended session. And so, and that's one of the reasons why since they're recognizing it as being in that longer session, that's why they're trying to sort of corral people away from it. And so, again, there are insurance companies who are saying, you know, that's the longer session and it really isn't needed. And as far as I know, United Healthcare is the only one who's requiring pre-authorization for that. And so there are certain guidelines that they look for those longer sessions, and they're including things like there are certain diagnoses such as PTSD that that will meet the guideline for pre-authorization for United Healthcare, or, you know, for that prolonged exposure kind of therapy will meet that guideline. So in other words, if you're reaching out to United Healthcare and you're trying to get that pre-authorization, those are the things that you would need to show, hey, here's my diagnosis, or here's the treatment that I want to do, that would get that pre-auth. The other insurance companies right now aren't really looking for that. They are just saying, you know, you can bill it, we're just not happy about why you're billing it, or we think that you're billing way out of line with, you know, where most insurance or most providers are.
And let me just add that we think of 90832 as a 30-minute, 34 as a 45, and a 37 as a 60-minute session code. But the technical guidance on it is that the 90834 code runs anywhere from 38 to 52 minutes. There's a range in the actual code guidance. And 37 is for 53 minutes or longer. So longer, I guess, is 90 minutes. The issue became a little more convoluted historically back when the codes came online, because unfortunately there was a walk across between the old codes and the new codes that came out from APA, and it showed that the old code 90808, which was over an hour, was equivalent to the 90837. And some insurance companies have hung their hat on that definition because it came from psychologists. We've, in our practice, spent a tremendous amount of time trying to educate the carriers about that, and I think gotten far down the road of helping them understand why you have to have a 90837 code if you can document the need for it. But again, up to 52 minutes, if you think about the 50-minute hour, 90834 actually captures that. And it's only face-to-face time, by the way. The code doesn't include pulling the file before the session or charting the notes if you chart them after the patient leaves.
So I have a kind of a stupid question. I'm helping with the assembly because I'm an officer, not because I bill insurance. So are you saying, like, if I were in private practice and we're trying to bill for a 90-minute session, would I have to bill the same amount for a 60-minute session as for a 90-minute session? Wow.
Unless you can, I think unless you can identify a reason for a complexity code to be used as an additional code. If it were me and I were going to do 90-minute prolonged exposure sessions with patients, I don't, even though I'm pretty proficient at prolonged exposure. I would probably design 90 minutes outside the session. But if I did a 90-minute session, I'd do a pre-auth contact point with the carrier to make sure that I knew exactly how they wanted to code it and that they were adequately valuing.
But you know, it's really a good question, Catherine. And the point is that the codes have these definitions, and right now anything that is considered to be 60 minutes or longer, or I think, what was it again? It was like 57 minutes or longer, or 54 minutes or longer. Anything
right, 53.
53 minutes or longer, you know, it's considered to be that 90847 or 90837. So that's for a prolonged exposure session, that's the code that you would use because it's open-ended. Now, the question, I think the reason that we're really talking about this is because of, we'd like to be reimbursed for our time. But another factor to consider with all of this is that in their efforts to sort of close down on some of this, one of the tactics that the insurance companies have used is there is a very small difference right now between 90834 and 90837 in terms of reimbursement. So you can say, hey, I'm going to fight for this. I'm going to use my 60-minute session. I'm going to have a prolonged session, but their reimbursement rate isn't that much greater for that, for some of the companies.
Yeah, I'm also seeing Dr. Kaufman's comment that the complexity code only adds about $14 for Medicaid. It's possible one of their strategies is to make it so we don't fight for the small things,
yep,
and then we slowly lose ground.
That is absolutely correct. Yeah. Yeah, they're looking for different ways to sort of, back us into a corner with all of this.
So there's a question about family treatment. And Dr. Davies is saying she's received denials for 90847 and 90846 from some small insurance companies who say they don't have to cover family treatment.
Right. So, the important idea that I think, is helpful for everyone to remember, our, diagnosis codes, come from that whole ICD-9 or ICD-10 network. And then our CPT codes come from the American Medical Association. And so just because these two entities are creating this way of classifying what we diagnose and what we do, it doesn't mean that the insurance companies are covering it. And this is a hugely important point, especially when we're thinking about making money. Be familiar with those things that the insurance company does cover and that they don't cover, the diagnosis that they cover and the diagnosis that they don't, the procedures that they cover and the procedures that they don't. Otherwise, you can wind up billing something and they say, I'm sorry, it's not in the contract, we don't cover that. Now, I would take us back to this idea here that we as an association advocate in this area. So in other words, a little bit earlier I was talking about that we have, a group that right now, a coalition that I'm a part of, and it's the psychiatrists and the psychologists and the social workers and the clinical counselors all coming together, and we want to interact directly with the insurance companies. And this is a part of what we want to do. We'd like to be able to say, hey, we see a real need for these procedures, or we see a real need for these diagnoses to be covered. What's going on here? How far we'll get with that, I don't know, but it's a way of pushing back.
I really appreciate your feedback, Jim. I was feeling like if I were in solo practice, I would feel a little overwhelmed by, having to figure all this out ahead of time, having to try to get paid for my time. And so, Dr. Arnold, your larger practices was looking more appealing because at least I'm not alone in trying to figure all this out. But it sounds like, Jim, through OPA, we do have some recourse to try to manage this.
That's true, but this is, I think, part of Kevin's point. Part of what he's saying is we do have resources through OPA, but that should not undermine the idea that it's going to be working so much better for all psychologists in the future to move away from that individual practice model. Because when you talk about things like the electronic health records, when you talk about things like outcome measures, those are the kinds of things that become almost cost prohibitive to do when you're an individual practitioner. And when you're joining forces with others, then it becomes more doable. And the insurance companies know that, which is why they'd like to see us moving in that direction.
And let me just add to Jim's point, if I could. The models I discussed before don't require an individual practitioner to be owned by the larger entity. They're associations or organizations, and the term members almost always apply to the people who, participate in them, so that you can gain access to some leveraged resources. I mean, there's going to be a cost involved to it, but you don't have to be owned by that office. You're, in fact, buying services from it. Let me just make a point. We've, over the last 2 years, gone out and audited several other practices to look at whether or not they would become a part of our practice. And the shocking thing to me is that when you make equivalent the amount of money that they get off of a billed dollar, so when you take our rate and you make their rate our rate, and you take a look at, on the same contracts with the same write-offs, what they're bringing in on a billed dollar, the variability is as high as 35 cents. So that we've seen practices that are only bringing in 20 to 25 cents on the billed dollar. We bring in, based on our rates, about 58 cents on the billed dollar. That money is being left on the table because they'll do denials, and folks have billing companies, and they believe that the billing companies are working the denials to claims management. Excuse me, and that's not in fact the case at all. So a careful attention to what the organization is bringing to the table and making sure it can show you that it can deliver more efficient, read that as higher return on the billed dollar, is a pretty important thing to do when you're looking at either a billing company or an organization. You want to make sure that they actually are doing something that you're not already doing, and you're just paying them to do something you could have done on your own.
One of the things I'm noting is that the folks who've spoken so far are our past presidents and our board. So I notice our members are using the chat to communicate, and would love to hear the actual voices of folks who are on the call, calling in to discuss. I wonder if anything's come up this last discussion here about moving away from solo practice that's interesting, or you'd like to ask a question about or mention.
I'll make one more comment. One of the most common questions, or I don't know if it's a question, it's an expression of frustration that I hear from our members is, we haven't had a raise in 20 years, which is true. And if you look at reimbursement rates from insurance companies, they haven't moved in a long time, okay? And so one of the things that we say is that it can be really important to, often when folks are working together in a group and they're billing together under one group tax ID, it becomes possible then to negotiate with the insurance company for your reimbursement rate. And sometimes certain groups, for various reasons, can be perceived as being, more value, especially if they're following some of the guidelines that we're talking about here, and they get it. Then often insurance companies are more willing to negotiate that rate with that group.
I would just add to what Jim said that when you join an alternative practice model, there's a term that I often hear the APA legal and regulatory attorneys talk about, it called the messenger model. In the messenger model, the organization serves to not so much leverage and make threats to the carrier. It's got to be carefully crafted. The organization takes the message that the practices that it represents are tired of the reimbursement rate. They don't feel that it's adequate enough. What are you going to do about it? And then whatever the carrier responds with is then messengered back. And any of the member organizations practices have the option of saying, no, I'm just not going to do that. And they drop off the panel. It's a fine line, according to Alan Nessman, the attorney that I work with a lot at APAPO. It's a fine line in how you do it. And as long as you understand how to do it, you keep yourself out of trouble with the Federal Trade Commission.
So can I say also, the questions that I get to me individually or through email sometimes can about reimbursement and insurance sometimes can be a lot more basic than this. So if you're on the if you're part of our meeting here and you have just even some basic questions, please feel free to ask them. You know, that's a fine. This is a good place for that, and it keeps me in touch with the kinds of things that our members need to know.
Yeah. Melissa, I wonder if you want to share your question out loud for us here.
Melissa, you might be muted, maybe.
Yeah, just if you can unmute, I'd love to hear.
Can you hear me now?
Perfect.
Yeah, hi there. I just wanted to offer another perspective because I know a lot of people are moving to group, and I practiced in a medical group for about 9 years before I opened my independent practice. And I have to say, I've just really enjoyed it. And there are the stressors, a lot of what you guys are talking about. Certain insurance companies are a real headache. And I really got to a point where I'm just like, I don't need to deal with this anymore. So I bow out of the contract. And, you know, I've still been able to have a very thriving practice. I practice in a kind of a rural area of the state. So there's, unfortunately, a long wait list trying to get people connected with services. So maybe that kind of puts me in a different position as well, where I can be a little more selective on the insurance panels that I sign up on. Excuse me. Yeah, so I just wanted to offer that different kind of perspective as well.
It's really a good point, because on one hand, panels are losing quality people, you know, and you're an example of that, Melissa.
Yeah.
On the other hand, they tell us that, hey, we've got plenty of people on the panel and everything's just fine, which we know is not always the case.
Right. Yep, most definitely.
And I think you being in a rural setting creates not unique, but bordering on unique opportunity for you because of the lack of access due to the insufficient coverage of behavioral health services in rural areas. One of the things that folks who are serving in rural areas, if you did want to take insurance, not that you would, but if someone did, I would certainly be sitting down with the carriers and pointing out that they need to pay more because the services are in higher demand, and the barriers to access to service in rural areas says to Medicare, for example, it identifies areas where certain kinds of waivers are available automatically because of the lack of access. So I think being in a rural setting presents challenges, but also opportunities.
Yeah, I would agree, most definitely. It's a unique way to practice, and I was born and raised in this area, so I feel like I have a way of connecting with a lot of the patients around here. But we need to talk about ways of having more providers so that we don't have such a shortage of folks. And trying to get the insurance companies to understand that is, almost a losing battle. There's certain insurance companies that have told me that they're saturated with providers. And it's clear to me that that's not the case, but, some are great. Some of the companies are great, and then some are not. So you just kind of have to figure out who's who. And that's kind of a trial and error process, at least in my experience for my practice thus far.
Yeah, let me, if I could address a part of the point you just made. When we hit that kind of wall with a carrier, we're pretty heavy on data collection on the front end during intake processes. So we know the employer for almost all the patients. When we identify that kind of a barrier from a carrier, we will go to an employer that has purchased that carrier for their employees and let the HR director know that given the way that the carrier is reimbursing or creating barriers to delivery of service, we're not sure that we can continue to take that carrier, which means that their employees are paying for a service that they're not getting because they can't have access to it. And the HR directors have a little bit more leverage with the carriers. I think you have to be careful with the way you do what we do, or at least our attorney Glenn Carr tells us we got to be careful about how we do it. But one of the things for us to always remember is that the person sitting in your office seldom is the one who's paying for the insurance that they're using, and that the insurance companies are much more likely to be responsive to the people cutting the checks to their insurance company than they are the patients who are the recipients of those checks that are being cut by the companies.
All right.
So, one of the things that occurs to me when I'm hearing Kevin talk is that, Kevin is pretty well connected, and he knows who to call and who to talk to. And some of us are just waiting on hold after we call the 800 number for about 2 hours, which is one of the reasons why we get so frustrated with insurance companies. So, that's another area of support that I often will provide for people is sometimes if, you're trying to get connected and bring a particular case to an insurance company and, you're on hold for like 45 minutes, sometimes I have the connections with some of the companies to be able to talk to the right person, to be able to talk about some of the things that you're experiencing. And some of the people higher up in the insurance companies are not really even aware of this because they have a pretty effective wall around them. And then also be aware that the Ohio Department of Insurance has a specific avenue of complaint for contract and credentialing issues, such as the ones that we're talking about here. It's a whole different kind of complaint. It's not about that your claim has been denied. It's about, hey, I'm having this problem with my contract here, or I'm having this problem getting credentialed, or being able to have my value here recognized. And so that's another avenue too, and I help people understand what those avenues are, and that can sometimes be a helpful thing. And again, our Ohio Department of Insurance, goes through phases where it can be pretty powerful as a consumer advocate, and it goes through other phases when it tends to be pretty benign and has very little power, and that depends on the actual administration that's in power at that time. So elections are coming up. Go vote.
Yeah, I just put in the chat room that we've got only about, my math skills are poor this morning, 13 minutes left for this discussion. And then we'll shift to, what the board is going to be prioritizing for our strategic plan related to these practice issues. So would love to hear a couple more questions or thoughts from the members who are on the call here about what.
Hi.
Yeah. I'd really like to hear from the member. Go ahead.
Hi, this is Adrienne Jett. I just have a question about for folks who are thinking about starting a private practice or independent practice, or who are new to it. I'm coming from the ECP perspective. I guess what advice would you give those folks specifically? And I mean, you've given us lots and lots of information, but what advice would you give specifically to folks who are trying to figure out whether or not to get on panels, which panels to get on, just kind of how to take all of this information and make sense of it as they're starting or deciding to start an independent practice?
Well, I can tell you that from my perspective, when you're setting up your independent practice, you should create some kind of entity that that creates a little bit of a barrier between you and somebody who might be unhappy with you. So whether it's an LLC or a C Corp or an S Corp, but you should set some structure up like that. In terms of the panels to identify, it's not hard to find resources to figure out who in your geographic area, which carriers are covering the largest number of lives. And those carriers then become the ones who are most likely to have referrals coming through the door because they're covering the largest number of lives in your area. For example, in Columbus, it's a sort of a 1 and 2 between Optum and Anthem. But down in Cincinnati, Anthem has much more of the coverage than does Optum. Knowing those kinds of things helps you to decide where you're going to put your resources at first, because joining a panel is essentially saying that you don't want to get some referrals from those folks. And then there's marketing, but OPA, as Jim's pointed out, has a great marketing toolkit. We use our website and direct contact with physicians' offices. There was a time when physician office referrals were sort of passé, and maybe 10 years ago. Close to 50% of all the referrals in our office come from physician offices now.
So, Adrian, here's the thing that I would say. Most people in the world, in the private practice world today, would say that obviously you're going to be reimbursed more for your time if you're not on the insurance panel, because they significantly water down your reimbursement rates. Okay, but in some, due to some factors, it's very difficult to make a living if you're not on the insurance panels. So those are the kinds of things that you have to figure out for your individual situation. So in other words, there are some geographic locations where people depend heavily on their insurance to be able to afford to be able to have access to care, and other areas where they do not. Where people can afford more expensive, those more expensive out-of-pocket expenses. Okay, if you have an area of specialty that is in demand, you may want to consider. I don't really need to take the insurance because people have that willingness to pay out of pocket for my specialty. So it's a variety of complex factors to think about. What is the best step for me? I hope that doesn't make it too muddy.
No, that's
well, and
that's good. Thank you.
Well, one thing I'd add to Jim is that being in the Midwest, we're unaware of certain other practice models. One of the ones that's been pretty successful on the East Coast is the concierge model, where if you're taking just private pay, they purchase certain amounts of service and certain types of service on a monthly basis, and that you have to simply provide the access that they expect. It doesn't mean that they're always going to utilize what they're purchasing, but that concierge model is got quite a bit of success going on in the East Coast.
Where would we go to find more information out about that? Because that was actually something that I was thinking about and wondering about, the concierge model.
I would think the best first step would be OPA contacting the New York Psych Association, because the place I've seen it most prevalently delivered is in the greater Manhattan area. And I feel certain that they already have a bevy of resources.
Okay, thank you.
Yep.
Thanks for the tool, Dr. Davies, from Amazon. That's great. Mary, you had mentioned something relevant to Medicare.
Medicare Advantage. I'd love to hear her question or comment.
I can get myself unmuted. Sorry about that. Can you guys hear me?
I can.
Okay. So one of the challenges is Medicare often sets the rates that other insurance companies follow. And so in the last however many years, as Medicare goes, so goes other insurances. And what I've noticed is a proliferation of Medicare Advantage plans. And I say disadvantage only a little bit facetiously, because my practice is primarily geriatrics, and I'm on a listserv for folks who work primarily in long-term care facilities. And what we find is that not only do Medicare Advantage plans reimburse less, but they have more difficult pre-authorization processes, and in many times they will deny care. And so I use MediGold since that tends to be an Ohio plan, and it can take me up to 2 or 3 weeks to get authorization to see MediGold patients in a long-term care facility, because they won't panel me because I only work in long-term care facilities and not outpatient, and then the reimbursement almost is not worth the difficulty that it's taken. And so what my concern is that there was a research study just recently published that shows Medicare Advantage plans provide poorer care for older adults that are Medicare eligible. The traditional Medicare is actually better, but that folks are signing up for those plans in record numbers. And so I'm worried what that means for the future of reimbursement for all insurance plans, basically. So that's kind of my question and statement all in one, Jim.
You know, obviously it has, anytime that managed care is involved, then it has an implication for reimbursement rates, you know, because that's a part of what they do. It's sort of like a combination of, we're going to hold that bottom line by, you know, managing those reimbursement rates, but also making access to care a little pickier. You have to jump through more hoops to be able to get it. And the bottom line is that, you know, just like you know, with private insurance, as we go to more to managed care, reimbursement rates goes down, and access to care becomes more and more difficult. And there's no doubt that it will be going the same way with Medicare Advantage plans, and not just Medicare Advantage plans, but we're seeing that same trend happening right now with Medicaid. So in other words, you know, the state of Ohio wants to be out of the direct billing and reimbursement for Medicaid services, and they are moving very quickly toward Medicaid managed care. You know, and so we'll see the same thing there with the same kinds of restrictions, the same difficulty having access to care, and the same effect on reimbursement rates. So you're absolutely right. It's affecting all of these things.
Well, let me just add from the private practice perspective. This year, we've seen a trend of patients who are on Medicare being unaware that they've been placed on certain Advantage plans. They just literally get a card in the mail, and they're unaware of the change in the coverage. And as a result, they'll come in on any number of different carve-outs, and we can't seek reimbursement for the services. And we're unaware that that's the case because they're unaware that they need to tell us that they have different insurance, and that essentially constitutes different insurance. We haven't begun to put our arms around it yet. It's just begun to really sort of hit, but it's clear that Medicare is pushing their subscribers over into the Advantage plans, and that all the carriers are creating these Advantage plans in order to take advantage of financial incentives to the carriers. I wish I had more to offer on it, but
the same thing is happening right now.
We're just now beginning to identify it. Yeah.
Yeah, so there's one question that Heidi asked here that hasn't been answered yet. We haven't talked about that. Heidi, do you want to ask that question out loud?
Sure. I guess I'm a little bit confused about, because I'm just new to billing insurances and stuff. So if an insurance company does not cover a service, an example would be telehealth, as long as the client is informed, are you able to bill the client directly for that? Or if they're in their insurance network, do you not have options? Just confused about those kinds of things.
It's actually a really good question, and it's not an easy answer for it. So, you know, when these kinds of things come up, my standard answer is make sure that you check your contract. I don't want to be an attorney here, and I don't want to be, you know, in the place of giving legal advice. And your actual individual contract with that insurance company will actually tell you about what you may or may not do, how you may or may not interact with their clients. Okay. If you look at your contract, they should be able to tell you that. Now, more generally, I'll say this: like for recently on the insurance committee, the question came up of if a psychologist provides psychoeducational testing for a child, and that child and their family is covered by a given insurance company, will the insurance company allow that? Which is kind of similar to your question. In other words, the insurance company doesn't cover psychoeducational testing. They typically have as a part of their policy that they don't cover any kind of testing for educational purposes. So then the question becomes, can I then, as a psychologist, go ahead and bill that client for that same service, or would the insurance company prohibit me from doing that? So I did reach out to APA and talk with our attorneys there, Department of Legal and Regulatory Affairs there, about that issue. And what we're, essentially what they're saying is the insurance company's position has been, if they don't cover the service, then they're not going to prohibit you from doing that in general. So, but that, again, that shouldn't be a substitute for you checking out your individual contract.
So you're saying that you, in that case, they're saying that you could bill the client for that service because the insurance company doesn't cover it?
Yes, they're saying if a service is being provided by a psychologist that the insurance company doesn't cover, then the psychologist should be able to bill that without any kind of restriction or, you know, prohibition from the insurance company.
Okay.
Yeah, but I think your point about informed consent is a good one. It's always necessary from a regulatory perspective, that is to the licensing board, that you have informed consent, and you get that by publishing rates for the things that may not be covered by a particular policy, so that the patient knows ahead of time.
Okay. Thank you so much.
Maybe we'll take another 2 or 3 minutes for some final questions, and then we do want to launch into talking a little bit about our strategic plan. So maybe, like I said, 2 or 3 more minutes.
Well, since nobody's asking, I wanted to make a point if I could. Jim was kind to say that I have developed contacts inside the insurance carriers. Surely we have. But we would have never had access to those kinds of contacts had it not been for the leadership and volunteer time that I committed to OPA and to APA. So there are a lot of times that people ask the question, well, what do I get out of the dues I pay, or what's, you know, why volunteer time? The success of our practice, and we feel we've done pretty well, is completely owed to OPA and APA and the resources and contacts that they provide. It's almost impossible to describe how much benefit we've derived from the things that OPA has given to me, you know, in terms of what I've done, and the access, particularly at state leadership now, practice leadership conference, and going to that. So if you talk to other people about why get involved in leadership at OPA or APA, because it pays itself back much greater than any investment that you've ever made, in my opinion.
Thanks so much, Dr. Arnold. Yeah, I did put in the links in the chat for the insurance committee's website and the professional practice committee's website. I joined the insurance committee call once or twice, and because I don't bill, it was like Greek. It was like listening to people speak another language with all the codes and insurance companies. But I imagine if you're a private practitioner, being on that call is really helpful to see, you know, what problems people across the state are facing with what insurance companies, and working as a group to troubleshoot those and try to make a change, both with the insurance companies and then at the state level. Then as we go up to the APA board and advocacy, OPA is advocating for you with your state legislators. And then I think, you know, you all mentioned APA and APA-PO many times in this call. If you're not an APA member, it's good to know that now if you pay APA dues, that does go to advocacy at the national level as well, to increase rates for being paid by Medicaid and Medicare, which trickles down to the other insurance companies. So you'll hear us talk a little bit about that on the strat plan call.
Can I say something real quick, Catherine, about that? We also advocate directly with the insurance companies. That's an important area of advocacy. And I just spent the past week making many phone calls and sending many emails to help out a practice in the Cleveland area who was owed about $100,000 by an individual insurance company, you know, and we were able to actually get that problem solved, and knock on wood, so far, we think those reimbursements are on their way right now. So it's advocacy also means running interference directly with these insurance companies too. And that's some behind the scenes stuff that nobody really knows that I do.
If I could, I'd just add that We never send an email to CareSource about a problem with getting reimbursement or credentialing that Jim Broyles is not copied on, because it scares them.
I don't know if I don't think it's fear. I think I have a good relationship with CareSource.
Whatever you might say, but it causes an outcome.
This is a great transition to the strategic plan, because I think, you know, as you're an OPA member and doing your practice, you do have the strength of OPA behind you, directly through Jim, as he can help you advocate and give you pointers. But also, we now have this strategic plan we're working on that Justin Dewberry and Stephen Nifley have crafted for us with the help of members and so on. So let's go ahead and transition. Eric, do you want to make that transition for us?
Certainly. So this virtual assembly came to us through a data collection activity and surveying what our membership is actually looking for us to try to add value to being a part of OPA. And so we thought that this topic of reimbursement and practice models would be an important part to cover today. And part of how we get there is through the strategic planning process. And both Dr. Dewberry and Dr. Nifley have just done a remarkable amount of work trying to organize all of this disparate information, trying to come up with some cogent themes related to our strategic plan. And although I appreciate that sometimes strategic planning isn't maybe as captivating as insurance reimbursement, we do have to appreciate that strategic planning does give us a compass of where we're going to go as an association in the coming years. And we definitely will use that to try to transact the work on behalf of our membership. So I would like to turn our conversation over now to Dr. Dewberry to give us some sort of broad strokes about the strategic plan, and then Dr. Hano, who has been a part of this planning for the last couple of years, as well as in addition to our new governance model, to kind of help with that. And then we will come back around 11:55 to wrap up this assembly and some parting thoughts. So Dr. Dewberry, I saw that you joined us here. If we could turn over the conversation to you, sir.
Yes, absolutely. Thank you, Eric. Happy Saturday morning to everyone. I was encouraged to join this part of the call so that you all could kind of hear firsthand what the arc has been in creating the strategic plan, and really so that we can ask two things of this group. One is, as you had the opportunity to, I believe the strategic plan went out to this group, those who had registered for the assembly, to have a chance to kind of look over it and maybe digest some of where we think we're going, because as of where it stands right now, the draft you saw has been approved as like a first read draft by the board, and by November's board meeting we hope to have a final vote on, is this the initial version of kind of the final initial version that we'd like to pursue over the next 5 years. And you'll understand why I say kind of final initial version here in a moment. But we hope two things kind of come out of this. Is one, we can get your feedback on how it resonates with you, how you feel about it. Do you think you would be pleased if OPA's board and staff and the involved members kind of pursue these strategic priorities and subsequent initiatives over the next 5 years? And if we were to have success and achieve some of these initiatives, if not all of them and hopefully more, would that look good to you? Would that be a ideal outcome to you? And then actually subsequent to this, we hope that it kind of gets people thinking of like, wow, I really like that initiative, or I'm really passionate about that initiative under that priority. And similar to what Jim and Dr. Arnold were just saying, like, where can you get involved? Where might you be able to plug in that you haven't previously plugged in as OPA takes up some of these priorities and initiatives and moves them forward? Where can you put your voice and your skill set and your advocacy and just your kind of elbow grease behind some of these initiatives and help move OPA's strategic plan forward? So let me kind of back up before we go forward and tell you the story about where this has come from. And let me first check it. Does Stephen Nifley happen to be on the call? Stephen, are you in the room and I'm not seeing you? Okay.
I believe so.
So my partner in crime in this foray has been Stephen Nifley. We are both graduates of, what year was that? 2017's OPA Leadership Development Academy. We're both fellows of that program. And shortly after that program kind of concluded, was about the time Mary Lewis was coming in as president, and she reached out to the two of us and said, you all have talked a lot about kind of strategy and the business of what OPA is in. Would you be interested in helping me kind of regenerate this strategic plan that OPA can follow for the next few years? And the answer from both of us was unequivocally yes. It was a very exciting invite to have. And so starting basically toward the middle to end of 2017 was when this all kicked off. And if you haven't participated in like the member survey, we will post more publicly kind of the long history of this on one of our web pages that we've already been populating. And if you did take the survey, you might have already clicked on one of the links and seen this kind of written out as to the arc of where we're at right now. But it started last year. We started by reviewing historic strategic planning documents of OPA. We condensed a lot of that. Actually, Stephen went back through and did a lot of qualitative analysis of the focus groups that had been run historically, because it had basically appeared that about the last time OPA was actively strategically planning and following up on it was around 2011, 2012. Then a lot of the biggest strategic push had been toward the implementation of the new government model led by Kathy Ashton and Catherine O, partnered by many people, and then kind of finalized as Mary Lewis came into her president role and then transitioned over to Catherine's president year this year. And so it was also the opportunity that as we are completing the implementation of this new OPA governance model, let's make sure that they have something to work on and something to really dig their teeth into once this new governance model comes to be. So kind of winter of 2018, we took a lot of the data that was already available and some of the new data where we had asked all the incoming VPs in this new governance model to give us their perspectives on where they thought strategic priorities were for OPA. Over the course of spring into summer, we did a lot of condensing of those dialogues, kind of did some affinity groupings after a presidential trio and executive officer meeting in the January timeframe as well. Coming into summer is when we really started to look toward the rest of the leadership group, which would be the VPs and the committee chairs and all the committee members, as well as then looking toward the general membership. And in subsequent surveys, with the leadership survey happening around the June-ish timeframe, and then rolling into the general membership survey happening around the end of July, August timeframe, we were able to generate a lot of data about the priorities and the initiatives that had already kind of bubbled up and percolated to the top, which, by the way, we were always very excited that we were about a step ahead of APA in doing our strategic planning, and that made us feel very good. And also that as we were coming up with our data and subsequently seeing APA post their data, we weren't too far off. The things that APA were coming up with was obviously more nationally driven, but we were all playing in the same ballpark. So that felt really good to see the parallels between what APA was finding a step behind us and what we were a step ahead hearing and finding too. So the current iteration of this strategic draft is a product of the last two steps we went through, which was the leadership survey, the general membership survey, end of July, early August, and then a multitude of kind of board dialogues that had been held in the end of September, beginning of October, prior to the October 13th board meeting. I want you all to know, because I don't think this piece is more publicly available yet, although for transparency's sake, we're going to end up posting all our trajectory in this strategic planning piece. But we had 422 responses to our general membership strategic planning survey. It is the largest response rate we've ever received for any type of OPA survey ever. And it was unbelievable. 422 responses, which at the time, kind of at the close, it represented about 27, 28% of the entire membership at that time. So, you know, just shy of a third of the membership participated in the general membership survey. And we felt really good going forward into having the board dialogues and then crafting this kind of initial draft, that we had a good set of representative data. By and large, as you'll see, one of the strongest things that came out, and hopefully you see reflected, especially in priority 2, is evidence of the OPA kind of guild, especially those in private practice or practicing in a group or some other method of kind of practice delivery, is really around the insurance stuff, which is what prompted this assembly's topical discussion today. And then we also focused in on the opioid crisis and the initiatives around that, and then other ways of just aligning and allying with communities and systems.
Great.
So at this point, I'll ask for, yeah.
Oh, I'm sorry. I want to point out we've got about 8 or 9 minutes to get feedback before we wrap up. So anything else you wanted to get in before we get member feedback?
I was ready to turn it over and say I'd love to hear people's kind of resonance on this plan thus far.
Fantastic. So I just shared the PDF. If people didn't have it up, it's there in the chat. Particularly interested in priority 2, since that's what we've been discussing here. But yeah, what thoughts, what input do people have about the strategic plan in front of you there?
Is this something folks would be proud about OPA accomplishing over the next 5 years? Like, as you look through some of these initiatives, you'd be like, yeah, be really happy, really thrilled, really proud of OPA for achieving that if it was to be achieved over the next 5 years.
And ultimately, is that where you want to see your professional association trending in the work that we're doing on behalf of our membership? Because ultimately, OPA is here to service our members. We're doing a very nice job with the therapeutic use of silence as well.
Yeah. One thing I might do is just mention the 6 initiatives under priority 2 and see if folks can weigh in on, you know, which ones they really see as most important, or if there's an initiative there that you think, you know, is missing. So maybe something you'd like us to be doing around practice and reimbursement. So the initiatives have to do with coming up with specific methods that work with insurance companies to make sure they're actually providing parity, so that we're getting our fair shake with insurance companies. Funding research studies that look at practice efficacy and where psychologists are uniquely qualified. Working with APA more to change Medicare and Medicaid reimbursement. Providing scholarships for minority students with economic need. Enhancing OPA member consultations with Jim for practice and with the ethics committee for ethics. And then passing the RXP legislation that would give us prescription privileges, and making progress on the SIPACT legislation, which would enable more telehealth across borders of states. So what strikes you as particularly important or interesting, or is there something missing there?
I think the one question that stands out to me more than anything else that I would like to know more about is this what I want my association to be doing for me? You know, is the work that I provide what I want my association to be doing? Would I rather see them be focusing on something else? You know, this is a great opportunity to be able to talk about that.
Particularly because we have a great continuum and diversity of practitioners on Zoom right now, from ECP, we've heard earlier, all the way to more veteran and very well established practitioners. And we're certainly interested on both sides of that equation.
I wanted to mention, I'm pretty familiar with these initiatives, being on the board. But I just wanted to say that I am particularly, and I don't know if I've said this before, but I'm particularly interested in working with APA on addressing the concerns with the Medicare and Medicaid guidelines. I have heard quite a bit of conversation today about, you know, being paneled with insurers, making the decision not to be paneled with certain insurers, working with people who are able to self-pay. And that kind of saddens me to some degree, because I mean, it's nice to be able to do things like that, but at the same time, when you consider people who don't have those type of resources, whether they be people from a marginalized group, people from low income, or an aged population, you know, over the age of 65 and not working, or maybe even people who are on Social Security disability or have other disabilities that can be recognized. They may not have the resources to access people like us, and they may be the people that are most in need. So I really do feel like it is nice that we have the option to be able to move away from insurance, but at the same time, we may be missing out on a group of people that really need our services, also to include people that live in rural areas. We really need to find ways to change these regulations so that we don't have to continue to do things like that.
Mary's comment earlier, Elizabeth, about the changes that are happening in Medicaid and Medicare with Medicare Advantage and Managed Medicaid is very relevant to what you just said. Those changes are happening and those populations will be affected.
Yeah, thank you for offering that up, Elizabeth. Go ahead.
Yeah.
Oh, thank you.
Yeah, this is Maria.
Oh, I'm sorry. I was just going to say one last thing, and then you go ahead, Maria. But my understanding also is that insurance companies actually follow what Medicare says. So hence the reason I say that it's probably really important. But go ahead, Maria.
Okay, yeah, thank you for your comments. I completely agree with you. I was wondering about OPA efforts, maybe in the area of integrated care. Just when it comes to helping hospitals get reimbursed for integrated care, offering psychological care with medical care at the same time. Because that would be a way to access a lot more people.
So are you saying, Maria, that you're thinking that the strategic plan ought to reflect a real emphasis on helping people to understand integrated care and how to be
Hello?
Yeah, Maria, can you state that again? What would you like to see more of in the strategic plan related to integrated care?
Yeah, so a number of things. When I was looking at priority one, and I can give you an example. I'm working now with people with opioid addiction. And in order to serve them, what I had to do was to partner with the Hamilton County Court. So basically, and I'm sorry, I'm driving. I'm like, I was going downstairs and I'm driving now. But hold on. But I wanted to say something about that. And I really like what Elizabeth has had to say. I mean, I feel that when we think about accessing people who are low income and in the greatest need for mental health care, we have to think about partnerships with multiple organizations. So not just physicians, but the criminal justice system, police officers, schools, just everybody. I think that everybody's getting impacted in some way or another. And for example, so when it comes to the women I see, they come from they all grew up in poverty. They all experience severe trauma, and they have found that, so someone who experienced at least 5 ACEs, 5 adverse childhood experiences, they're 5 to 10 times more likely to inject drugs in the future, for instance. So that's something that people usually don't know that we should be able to educate the population on. And that will be a partnership with the schools, and it will be more about providing trauma-informed care, providing trainings for psychologists, but also trainings to other providers. So what I do is I have a contract with the court, and I go there once a week, and I meet with the judge and the other providers and the lawyers, and we discuss all the cases that are going to be heard on that day, and I give recommendations to them that are trauma-informed and culturally competent. And I also see all the people who are being seen in court in my practice. And then we partner with providers who offer, who train the women to go back to work, who train the women on parenting skills, who provide them clothes, who help them with food. So there's just so many other factors that are impacting the opioid crisis that I think we should be looking at. Hello?
So Maria, this is Justin. I think you should be one of the people we highlight about figuring out another kind of method or channel or modality for practice. I think your contract with what it sounds like is one of the drug courts is an ideal way to think about accessing in a way that gives you a different revenue channel, right, for a business purpose, but then also allows you to access a critical in need population. I'd love to see you highlighted as one of our psychologists that's doing some really unique things in that way, and maybe even be able to, because where I hear where I see the strategic plan touching on what you're talking about is both in Initiative 6 under Priority 2, where it talks about achieve legislative wins and equip Ohio psychologists for innovative behavioral health practice delivery. That would include, under the measures, that would include people in primary care mental health integration settings, as well as all the partnerships we outline with physician groups and initiatives in Priority 1. But I would love to have you highlighted as one of those psychologists that's doing something pretty unique and different that probably not a lot of psychologists are thinking about as an alternative revenue stream for their business, but also a way to serve a really in-need community of people.
Oh, thank you. Yeah, I would love to.
And Maria, we will reach out to you, and I don't think we could have structured a better final set of questions there from you. Really not only speak to the overall assembly with respect to looking at different ways of monetizing and supporting our growing practice and different practice models, but also really kind of encapsulating all 3 of our strategic plan priorities, from the opioid crisis to professional practice to integrating and collaborating with diverse systems. So you really did integrate that very nicely. So thank you for that. And Catherine, as I'm looking at our time, I see that we're kind of coming to an end here. We have reached 12 o'clock.
Yeah, I really want to thank everybody. This was our second virtual assembly. We got more participants this time, and really such a variety of folks. I think we got more folks participating this time who aren't on the board. And so I really love that that worked, that we got a lot of members joining in. And I hope that it was a great use of your time, and that you'll continue to access the resources you heard about today, and reach out to any of us in the leadership if you have questions or want to give further input. We're hoping to finalize the strategic plan in a few weeks. And that's all I have. Does anybody have a final thought to share before we sign off today?
Maybe Kevin, if you could give us one profound sign off. Put you on the spot all at once.
How about if I'll give a pitch.
Okay.
The presidential initiative for 42 that I'll be heading up next year, excuse me, is integrating as independent practitioners into primary care offices. But I think it's relevant to several of the points that are in the strategic plan. But we're going to hold a meeting down in New Orleans in February that will include Kathy Ashton and Division 31, because 42 understands that we can't disseminate anything of value that we'll, excuse me, put out in a toolkit, which is our goal, if we don't do it through the state associations. But I also just wanted to point out that it's pretty cool that of the 8 people that'll be in the room, 2 of them are former OPA presidents, and the third, Jared Skillings, was a recipient of an OPA undergraduate research award.
Fantastic. Thank you for that. And Jim, a parting thought from you, perhaps?
Just stay in touch. You know, I'm available, and I put in the chat a second over here, I put my email address. I didn't include it in my handout, but please feel free to reach out to me if this has stimulated individual questions for you. Please feel free to reach out.
Well, with that, thank you, Jim, too. So again, I'd like to really extend our appreciation to Dr. Arnold and Dr. Broyles for both lending your Saturday morning and your expertise from 2 different perspectives with respect to the overall assembly. Also, I'd like to thank our OPA staff who made this possible and our board members. But most importantly, I'd like to thank each of the members who took their time this morning. And I hope that this was an appropriate use of your Saturday morning. I know our weekends are always valuable to all of us. I will type out these notes and then share between Michael Ranney and Dr. Broyles and Dr. Arnold. And then we will share these notes and then let them embellish as well. And then at this point, I believe this brings to conclusion of our fall 2018 virtual assembly. Thank you all, and please have a wonderful day.